Okay, good afternoon, and I would like to thank the organizers for giving me the opportunity to speak to you. I was asked to talk about what is new in the 2016 European Guidelines for the Management of Dyslipidemia, and I had two problems. The first one being that the only thing that is more boring than listening to a talk about guidelines is giving one. So, for those of you who just want the bottom line, a few spoiler alerts. Kevin Spacey is Kaiser Soze. Bruce Willis was dead the whole time. And nothing much is new in the 2016 European Guidelines. So this was my second problem. What am I going to do for 20 minutes if nothing much is new? So what I decided to do is bring to your attention some of the issues that I see as controversial, and these are pretty major issues, and maybe pick a few fights along the way. And yes, by the way, Edward Norton and Brad Pitt are the same person. Okay, so like we've heard from Professor Henkin, the Europeans continue to endorse the SCORE equations for risk assessment in primary prevention. And that is opposed to the Americans who upgraded their 2001 model Framingham into a new, shining pool cohort equation. Now, Professor Henkin discussed the differences between the SCORE and the pool cohort equations. I would like to mention what I think is a major issue here, that the Europeans compute the risk for cardiovascular deaths as opposed to cardiovascular events that is assessed by the American guidelines. And the Europeans say that they use the fatal versus, as opposed to the non-fatal events, because non-fatal events are dependent on definition, developments in diagnostic tests, and methods of ascertainment, all of which can vary. And we know that when we start using the newest hyper, ultra, mega sensitive troponin assays, we suddenly see a surge in myocardial infarctions when really nothing happened. So, if you want to extrapolate from mortality to morbidity, the total cardiovascular disease event risk is about 3 times in men and 4 times in women that of the mortality risk. Another thing about the score is that it can be recalibrated for different populations, and indeed there are calibrated versions for many countries in Europe. Regrettably, we don't have a calibrated version for Israel, so we use the generic version for low-risk countries. And I have to tell you, I contacted the ESC and the EAS multiple times to find out on what basis they decide that we are a low-risk country, what data do they have. I never got an answer for that. So what is better, the risk equations or the SCORE? When recently a large study from Copenhagen looked at it and compared in a Danish European population the poor risk equations versus the SCORE. And the first thing we see is that the SCORE tends to overestimate risk by a large margin, with a predicted to observed event ratio of 5 as opposed to 1.2 with the pool cohort equations. In fact, what we can see is that the C-statistic is moderate for both risk assessment models, with a slight advantage to the pool cohort equations. The difference is in the sensitivity and specificity. The European SCORE is very specific, but the sensitivity is only about 10%. The pool cohort equations are somewhat less sensitive, but much more, somewhat less specific, but much more sensitive. So, if you look at treatment eligibility, the American guidelines say that more than 50% of the adult population is eligible for statins. The European guidelines in the same populations state that only about 10% are eligible for statins. And the sad thing is that if you use the European guidelines, less than 50% of those who later developed a first or any fatal event, and I have to tell you, I don't understand what is first or any. There is only first, but this is a copy-paste from the article. Only less than 50% qualified at baseline for a class 1 recommendation for statin therapy according to the European guidelines. This is very poor performance. Why is that? Well, first of all, the score is based on databases like the Monica and others that Professor Enkin have showed, which started in the 70s and the 80s, a time where such hairstyles were considered legal. So these cohorts no longer reflect a contemporary population in secular trends in cardiovascular morbidity and mortality. So should we revise the score with contemporary data? There's the rub, says Shakespeare, because if you want to have enough data in a cohort, you need a long follow-up. By the time you have enough data, your contemporary cohort is no longer contemporary. And like Professor Shevin says, atherosclerotic imaging, and especially calcium scoring, is it ready for prime time? It has a much better statistic than the Framingham risk score. For me, the nice thing about it is that it has an excellent negative predictive value, which means that if you have a calcium score of 0, your chances of having a cardiovascular event in the next 10 years or so are extremely small, so we can avoid treating patients who don't need the treatment. There is a risk score based on calcium scoring, and there's even an app for it, and yet, as we've heard, both the American and European guidelines mention calcium scoring, but do not give specific guidance as to who should get it and what you should do with the results. Another problem with the score is that, as we've said, it assesses the risk of death, and it's becoming more and more difficult to die nowadays. I remember when I was a young doctor, people came in with myocardial infarctions and many of them died. Nowadays, it's a rare occasion to see a patient coming in with myocardial infarction and dying. And in recent decades, there have been dramatic declines in mortality from cardiovascular disease, but the decline in non-fatal event lags behind. There is not such a dramatic reduction in morbidity. In the Danish cohort, there were more than 10 times more non-fatal than fatal events. In the 40 to 65 years age range, there were only 78 fatal events as opposed to more than 1,300 non-fatal events. So maybe the score should include non-fatal as well as fatal events. The next issue about the score is that the US guidelines set the treatment threshold at 7.5% risk according to the pooled cohort equations. This is equals to about 2.5% mortality risk by the score, which means that the threshold for initiating treatment in the European guidelines is usually higher. So is it time for the Europeans to lower the threshold for statin initiation? And I think many people are already doing that. This is a study from the Netherlands. And among the patients who were on a statin, 2/3 were on a statin despite the fact that it was inconsistent with the Dutch guidelines, which are basically the European guidelines. Most of these patients who were not treated according to guidelines were not according to guidelines because they had a low 10-year predicted risk. But if you look at those patients, most of them had either an extremely high LDL cholesterol level, or 2 or more major risk factors, or a positive family history. So it's very reasonable to treat these patients. So maybe this is what the Europeans should do, lower the bar. Now, after you've computed the risk, you have risk categories, and I won't go over them. I'll just highlight the differences between the European and American guidelines. In the American guidelines, secondary prevention means that you had a clinical cardiovascular event. In the European guidelines, imaging is enough. You don't have to have the clinical event. And like it was mentioned before, chronic kidney disease is included in the high and very high risk categories. And after you've assigned a risk category, you have a target of less than 70 for very high, less than 100 milligrams per deciliter for high. As we all know, this is leads us to the next issue of the use of non-statin drugs, because statin drugs are the mainstay of therapy in the European guidelines. However, you use maximal statin therapy to reach the goal of LDL cholesterol. And if the goal is not reached, then a non-statin drug may be added with a preference for ezetimibe, and there is even a mention of the new PCSK9 inhibitors, and I had to tell you I was a bit surprised that they didn't wait, because these guidelines were published just 4 months before the results of the Fourier study were published, and about a year before the alirocumab results will be published, so they could have waited to get a more evidence-based recommendation according to the to the PCSK9 inhibitors. The Americans, on the other hand, say that there is no randomized controlled trials that compared targets. That one group was titrated to a certain target, the other group titrated to a different target, and therefore they opted for you are either statin eligible or ineligible, and if you are statin eligible, you are eligible for either high intensity or moderate intensity statins. So the question is to target or not to target. Well, there are no studies about a specific target, but the concept of lower is better is very strong according to data from multiple lines of evidence. Mendelian randomization studies show that people who are born with genetic variants that confer lower cholesterol levels also have markedly decreased LDL cardiovascular risk, and the lower the LDL genetically determined, the lower the cardiovascular risk. In people who are taking statins, there is a large variability in LDL cholesterol reduction. Some patients have a large reduction, some patients have a smaller reduction with the same dose of statin. However, it doesn't matter, because if you are on a statin, the lower your LDL, the lower the risk. And of course, we all know this graph, and we used to look at all the points on the graph and say these are statin studies, but this is no longer true. We have the IMPROVE study with the ezetimibe, we had preliminary results from the PCSK9 inhibitors, and now we also have the results of the Fourier study with evolocumab. So in 2016, there was a consensus panel that published a decision pathway on the role of non-statin therapy. And I want to emphasize that some of the people who wrote this consensus decision were also on the writing panel of the 2013 American guidelines, and they performed the most spectacular U-turn I have ever seen since Fast and Furious, because what they wrote is that it is appropriate to provide levels of LDL cholesterol, or thresholds, in terms of both percentage LDL cholesterol reduction from baseline and absolute on-treatment LDL cholesterol measurement, which, if not achieved by adherent patients, would serve as factors to consider in decision-making regarding further therapy. And this is just one example. In patients with stable coronary heart disease, if under maximal statin therapy, the LDL cholesterol did not reach 100 milligrams per deciliter, or a 50% reduction from the original level, then a non-statin drug should be considered. Now, I don't know about you, but to me, this sounds a lot like targets. But these are thresholds, these are not targets. So what's the difference between targets and thresholds? Obviously, one of them is good, you know, with a beautiful sunset and palm trees. The other is obviously bad, but what is the difference? And the writings say that they emphasize that these are not firm triggers for adding medications, but factors that may be considered within the broader context of an individual patient's clinical situation. Okay, now I see, because in the bad old days, when we used to have targets, if a patient did not reach the target, we called the police, we broke in, we tied the patient to a chair and pushed some pills down its throat. I mean, come on. Potato, potato, tomato, tomato, target, threshold, these are actually the same things. We always emphasize that you need to take the whole picture into consideration. What about LDL? LDL in both the American and the European guidelines is the recommended analyte for risk estimation and treatment. Non-HDL and ApoB are only recommended in patients with hypertriglyceridemia. However, many studies have shown that non-HDL and ApoB are better at risk prediction and even at monitoring treatment. Both guidelines write that, but still recommend LDL cholesterol. Why is that? I have not found it in these guidelines, but in the International Atherosclerosis Society position paper, I found this really remarkable sentence there. For historical and conceptual reasons, okay? Historical reasons I understand, I don't accept, but I understand. Conceptual reasons, I don't even understand what that means. Most panel members recognize LDL as the first target, although non-HDL was considered an equal target, and several members favored replacing LDL with the non-HDL. And this brings me to the next issue, fasting or non-fasting lipid analysis. Now, we have now data that non-fasting LDL cholesterol levels are as good as fasting LDL cholesterol levels. In terms of triglyceride, non-fasting triglycerides are even better at risk assessment than fasting levels. Even the European Atherosclerosis Society published a consensus statement with the title, "Fasting is not routinely required for determination of lipid profile," and yet fasting samples are recommended by the European guidelines, and the EAS is also a part of these guidelines, so I don't know how to reconciliate these two. What about Lp(a)? I don't know if you know a lot about it, but it is we now know that it is a causal factor in cardiovascular disease in terms of epidemiology, genetics, and animal models, much like LDL cholesterol. However, we do not have enough data about the metabolism of Lp(a). We do not know the mechanism through which it causes cardiovascular events, and most important, we don't have treatment and we don't have evidence that reducing Lp(a) will reduce events. And yet, the European recommendations state, and I quote, that including Lp(a) in risk evaluation should be considered in patients on the borderline, and I want you to hear that, on the borderline between high and moderate risk. And they give 5 types of patients in which Lp(a) measurement should be considered. 3 of those are definitely not borderline risk. They are definitely high-risk patients who should be treated intensively anyway, and Lp(a) will add nothing to the treatment of these patients, unless, of course, this is supposed to be the gateway to a cascade screening of relatives for Lp(a) levels, but they don't write that. If you mean that, please write that. Other topics in the European guidelines which I will not cover include lifestyle modifications, which Dr. Tzafir talked a lot about, treatment of hypertriglyceridemia, management of dyslipidemia in different clinical settings, including specific conditions, familial hyperlipidemias, heart failure, diabetes, acute coronary syndromes, chronic kidney disease, autoimmune diseases, transplantations, strokes, peripheral vascular disease, HIV, mental disorders, all of which have no mention in the American guidelines. There is the topic of specific populations, children, women, and the elderly, and like Dr. Tzafir said, strategies to encourage adoption of healthy lifestyle changes and adherence to lipid-modifying therapies. So to conclude, in my opinion, cardiovascular risk estimation using risk score is so 2001, and I think calcium score has reached prime time and should be included in the guidelines. Targets or thresholds, I don't care how you call them, are useful tools for treatment, and maybe they will be revised after we now have the 4-year, and in a year or so we'll have the Odyssey trial results. Non-HDL should be considered as both a risk marker and a target, and this will enable us to use non-fasting samples, which will be much more convenient for our patients, and more information is needed about specific populations such as women, the elderly, the young, and so on. Thank you very much, and if you have any questions, I will be happy to answer.
Thank you very much for this delighted speech. Excellent, provocative, and as usual. Any questions? I will ask you something. You know, following the Prove-It and following the 4-year and others, we still don't have the Odyssey results. Do you think we should, not we, but the European should change the target or something right now, or should we wait a couple of years?
Well, my opinion is that this may very well be the case in a year or so, because right now we have the Improve-It with some caveats, because the Improve-It ezetimibe was given on top of moderate statin therapy. We have the 4-year results, which are encouraging, but this is only one study. In a year or so, we'll have the Odyssey results, which will look at a somewhat different population of secondary prevention patients after acute coronary syndromes. I think that maybe after we have the Odyssey results, it will be worthwhile to reconsider changing the targets for treatment.
Yeah.
I beg to argue, I think the financial considerations will outweigh the decision to lower targets. You can get some benefit from lowering the targets, but the cost will be so enormous, it will be very, very selective.
Any other questions?
I have one information. I lost you on the issue of the score. On one hand, you said it greatly overestimated risk. Then you said its sensitivity was very low. How does that go together?
No, it had, so maybe I was mistaken. The specificity was very low. The sensitivity was very high, the specificity was very low. Thank you.
Thank you so much. We should go now.